Okay, we're finishing chapter 32. We're going to look at muscular dystrophy and botulism. Now, muscular dystrophies, there's several different types. We're only going to really focus on Duchenne's muscular dystrophy, which is the most common. But in all of them, what we see, they are genetic, so they're not, a germ or something that you acquire. They're chromosomal that you're born with, and they cause a gradual degeneration of muscle fibers. So you have this gradual loss of muscle control, which means the symptoms we're going to see are progressive weakness and wasting of muscles. It happens to symmetric groups of muscles, so it's not one-sided, it's bilateral. And because of that muscle wasting, we're going to see some disability and deformity, and it's progressive, so that is going to increase. I said the one we're going to look at is pseudohypertrophic muscular dystrophy, which is also called Duchenne's muscular dystrophy, and this is the most common. It's X-linked, so it happens almost exclusively in males. Remember, males only have one X chromosome, so if they get this gene, they have it, where females, because of the two X chromosomes, it's much less common. And what happens, that mutation on that gene, it causes a problem with encoding dystrophin, which is a protein that is needed for skeletal muscles. So that's what we see happening that's causing this muscle degeneration. And this shows the muscle groups that are primarily affected. You can see facial muscles, the muscles for standing, walking, and kind of holding the body upright. So these kids will usually start out needing just a little help with walking. They'll progress to a wheelchair. They'll progress to where they have to have a special insert to kind of hold their trunk up in the wheelchair. No cognitive impairment with it. And their hands aren't highly effective, although moving their arms are. I've seen patients who towards the end of their life still have enough finger control that they can push the call button as long as we can kind of wrap something around to put it right underneath that finger, but they can't move their arm to get to the call bell if it's not right where they can touch it. So the clinical manifestations of Duchenne, usually these kids progress normally till they're about 3 years old, and then we'll start seeing some muscle weakness. The parents will complain that, or bring them in saying, they used to be able to run and jump, and now they're kind of uncoordinated and they can't do what they did, and if they throw a ball that doesn't go very far, and that'll progress to their gait isn't normal. They're kind of walking funny, maybe even bumping into things. That will progress to where we actually are seeing muscular enlargement, but that's because the muscles have been infiltrated by all these fatty deposits, so it's kind of flabby muscles. And then usually, again, it's progressive, so usually by about 12 years old they can no longer ambulate, and the life expectancy is usually into the late teens or early 20s. And usually they'll die because of a respiratory infection or a cardiac failure. With the respiratory, they can't cough anymore, they can't forcibly cough, so any little thing that causes an infection can develop into a significant pneumonia, and that's how they'll die. Our goal of treatment is to keep them functioning as well as we can, as long as we can, and we may need to use steroids to do that, our corticosteroids. Here's how a child with Duchenne's is going to kind of push themselves up to standing, because they really don't have strong enough muscles to just hop up. They've got to work their way up. And our last topic we're going to talk about is botulism. This is a form of food poisoning. Botulism, it exists out in the soil, although the most common source of it is improperly canned home canning, and the most common improperly canned food is green beans. There's something about green beans that makes them much harder to can than other foods. So it's a food poisoning, and the symptoms come from the toxin that's released from the bacteria, not the bacteria itself. That it's an anaerobic bacteria, and in that anaerobic production or infection, it releases a toxin, and that's what really is a poison to our nervous system. And I said it comes from canned foods. So the symptoms we see are going to be central nervous system symptoms, because that toxin interferes with our nerve cells. Usually you'll start seeing symptoms 12 to 36 hours after ingestion. It progresses fairly rapidly. The treatment is to give an antitoxin. We do have a botulism antitoxin that we give IV, and we'll continue giving that until the paralysis has abated, till it's no longer present. And during that time, we're really just providing supportive measures. And one form of it we call infant botulism, and usually this one is not from green beans, because hopefully we're not feeding infants home canned green beans. It seems to be an ingestion of spores, and somehow often they find that there's construction in the area or something, so the soil has been disturbed, and there's probably spores, floating around in the dust or the dirt that's on the floor the baby's crawling on. But they somehow get those spores in them, and then it kind of sits in the gut, and that's where the infection proceeds from these spores that were ingested through and are in the GI system. And then those it releases the toxins which cause the problems, and there's colonies in the GI tract is where the infant botulism's usually started from. The only food that used to be given to infants frequently that we find it in is honey, and we've really warned parents not to use honey with children, so that's why the ones we see now with infants are probably something environmental that they somehow inhale or ingest. The symptoms, actually the earliest symptom is constipation, but that's such a general symptom it's rarely caught at that point. It's not until it progresses to generalized weakness and decreased spontaneous movement. This is a normal baby who's crying and moving, who the parent starts seeing this weakness and lack of movement, and they'll bring them in. So the treatment we want to treat quickly, because it does progress quickly, is to give the antitoxin, and that's going to neutralize that toxin and stop the progression, and then we just kind of have to wait out those nerves coming back. And here's a picture of a baby. This probably was a normal, healthy baby, and now you can see just sort of that floppy way the baby's laying, not holding its head with any stiffness, but floppy. And I have another picture here. This is a child. This is common, that the ptosis, the droopy eyelids. I've only seen this once on an infant, to be honest, and this is what the family brought them in for, was because of the ptosis, the droopy eyelids. And also, so the cranial nerves that control that, and the cranial nerves that control the pupils. You get fixed pupils. These pictures, it said this child was totally alert and oriented, but couldn't open his eyes. The pupils were non-reactive. The CNS symptoms we usually see typically begin with the face. So you get this paralysis of the facial nerves, and then it'll move to the arms, and progresses from the shoulders towards the fingers and move towards the legs, progresses from the hip to the toe. If someone does die from this, usually it's from respiratory, that finally the respiratory muscles and diaphragm will be affected. When we start giving that antitoxin, though, that the muscles will come back and they're just fine. This really leaves no permanent sequelae to the child. But we do, realize while this child has this ptosis and can't blink, we're going to need to be doing artificial tears in the eyes so that the cornea doesn't dry out. We're going to need to be doing good oral care because they can't really swallow and control their own secretions well. So it can be very serious, but it's also very treatable. And that's the end.